I appreciate the panel sticking around for a few more minutes, and we'll get right to the questions. Let me ask well, for the panel, but I'll begin with Dr. Cirillo. In your opinion, are hospitals and major medical centers getting enough federal funding and guidance to prepare for an influenza pandemic? And how do you propose getting all of the funding, resources, and guidance that you feel are necessary down to primary care providers?
I'll be honest with you, Congressman, that there has not been enough money, and the amount of money that it would take to say that we're fully prepared, if we could ever say that, is very significant. We did calculations in Rhode Island for a year-long pandemic in order to try and have enough medical equipment, supplies, and to be able to provide some reimbursement to healthcare providers who would come and assist the state. And the price tag for that was, for 1 year, was $550 million. And those were, rough calculations. But that gives you some sense of the amount of money that it would take to really continue to deliver health care to, an increasingly sick and large number of patients. I think what we've done is tried to build on those partnerships that we've had through the Hospital Preparedness Program. That's allowed us to try and, again, create common infrastructure, to create common efficiencies with the hospitals. The challenges that we face, though, is that even if we can stand up alternate care sites and find extra space, the issue of where will the ongoing supplies come from once we get through our initial cash, and where will we continue to find and recruit healthcare providers? We've discussed the issues of doing, if you will, battlefield promotions. How can we take medical students even early on in their career and quickly give them some just-in-time training to increase their ability to provide care? How do we take family members and teach them the basic skills of family health care to try and allow people to be taken care of at home or at an alternate care site or at a hospital? So those challenges of resources are still the critical ones that, although we can create that infrastructure, when the rubber really hits the road, I think my greatest concern is that the resources that we have will be utilized fairly quickly, and then it will become increasingly difficult to keep the same standard of care, and the challenge of decreasing standards of care or altering them really is something that's very difficult.
Let me ask this question, because it's funding related, then the panel can comment on either the previous question or the current one that I have. I understand that many of the preparedness grants from HHS, for example, are one-year grants. Why is this, and wouldn't it be more efficient to put more multi-year grants out there, which would encourage states and agencies to develop longer-term, more broad-reaching goals? We'll start with Dr. Cirillo, and then if anyone else would like to comment.
I think we've tried to encourage our federal colleagues to look at that as an option. I like to share a very Rhode Island sailing experience or sailing analogy, which is if I decide I want to sail from Newport to the Cape, I know where I want to end up. Along the way, I may have to change and tack with the wind a little bit, but I have a goal of where I want to be in a certain period of time. And on our level, if we continue to change priorities and change terminology and change strategies every year, it really takes more away from actually being prepared and devotes more time, money, and resources to just managing the program. And that's really not what we want to do. So I think a longer strategy, much as the bills and the programs are authorized for a multi-year basis, we would like to see at the state level that the grants are administered on a multi-year basis so that we can establish long-term goals, long-term strategies, and keep moving towards those in a coordinated fashion.
Any comment from the panel?
If I can maybe bridge the two questions, I agree with all of the previous comments. We've gotten substantial, although now declining, levels of funding to build laboratory capacity in terms of our diagnostic testing, our laboratory networks, and developing an emergency response culture that needs to be sustained. A lot of that money now is going to sustaining some very highly trained staff, where if the money goes away, we're going to be in jeopardy hanging on to them. I think Wisconsin is benefited probably better than some other states in that regard. I would echo the comment that, and then to make up the shortfall of funding essentially comes out of my operating budget in my division and ultimately my public health lab. It makes it difficult if we're making decisions on a year-to-year basis, never quite sure how much funding is going to be there and how much shortfall I'm going to have to make up. So we have enough. We've had an adequate amount to build a substantial capacity capability that needs to be sustained, but it would help us a lot to be able to do this on a multi-year basis so we can set up the long-term goals and maybe shift priorities.
Anyone else?
I can tell you that the national, county, and city health officials are very concerned that we have seen declines of 20% or more in the all hazards preparedness dollars that have gone out to local departments of health. And to know that the pandemic influenza preparedness funding is expected to terminate in August 2008. You know from your own experience that when federal resources are made available, that states and communities will take those resources and match them. They will do that more readily if they know there's a sustainable commitment over time. And a lot of this has to do with hiring personnel, as you are well aware, and that's the core part of what we have been trying to do initially, is to build our capacity of professionals to help us with the planning, as well as the development of partnership building, and ultimately of exercising and evaluating this. This is a long-term commitment. The long-term vision is there, and the federal government needs to provide the strength and the foundation to say, we are making this a priority in many ways through the passage of certain acts, that this is the goal that we have, the Public Health Preparedness and Emergencies Act, what it is we need to do, and also the resources behind it. When my county executive sees that there is going to be possibly a termination of funding, he is very uncertain of whether he is also going to be able to match money as well, or start a program and then know that maybe he will have to be fully responsible for it completely, and then not even know whether that may be something that could be implemented. So therefore, not only in my jurisdiction, but across the country, people are wondering, well, should we go and make the extra effort, or are we going to be stuck?
Very good. Dr. Lakey, any comment?
I think my comments echo the comments that have already been made, that we every year, significant effort comes from our agency in the whole grants management process of reallocating the funds, and having sustainable funding to the local health departments would go a long ways in getting them to step up and being a full partner in this. Actually, there's a lot of, on the local side, a lot of effort that they have to put into every year in this whole grants management project. I think also, on your first question, I don't think the hospital component is a huge issue. For example, in Austin, a city of 1.3 million, we'd expect that we'd have 13,000 individuals that would be hospitalized during a pandemic. And so there's significant preparedness activities that have to take place in the hospitals, and they need the consistent funding. And they also need to make sure that when that occurs, there's some flexibility on how they're going to be able to bill patients and be able to get the ongoing revenue if they're taking care of patients in a non-traditional manner, and different floors, et cetera. Are they still going to be able to keep the billing, being able to keep the financial security of the hospital during that time period? And that's an issue that I hear from hospitals when I discuss it with them.
Very good. Thank you. The chair now recognizes the ranking member, gentleman from Texas, for 5 minutes.
Thank you, Mr. Chairman. Well, first I want to say I want to thank the witnesses for their patience. I know it's been a long hearing, and we don't control the votes. At least I have no control over that, and thank you for being here. The long-term commitment is important on the part of the federal government on an issue that's so important as this one. I think long-term we'll have the technology, hopefully, as we heard in the prior panel, to develop the technology for vaccines that could be readily made within a matter of weeks. But until that time, we have to look at We have to look at antiviral medications and a whole host of other things to deal with this situation if it happens before that time. We are long overdue for a pandemic outbreak in this country. It's been about 40 years. First, I wanted to get a comment from the panel on, I asked this question of the DHS officials, but I'd like to get your perspective from a state and local level. How prepared are we and ready are we in terms of the antiviral stockpile in this nation in the event a pandemic broke out today? And why don't we just go down the panel, starting with you, Dr. Cirillo?
I was encouraged to hear, sir, that at the federal level, clearly the capacity, the production capacity has exceeded what was expected, and that is encouraging to hear. The federal government had established some federal stockpiles, and it sounds like they are meeting those goals, according to Admiral Van der Wegen. I think the challenge for us is that there is still an expectation that the states were going to participate through a negotiated contract in purchasing antivirals to keep at the state level. And while from a policy and strategic point of view we agree with that, the challenge is that that's an investment that really is at risk. And again, I would reference that those medications that we choose to stockpile at the state level are not currently available to be included in the shelf life extension program. So if I purchase N95 masks or hand gels, those are items that are really able to be used for lots of different events, and they don't go away, they don't expire. The decision to invest, scarce resources financially into antivirals, and if we don't have the next pandemic for another 4 years and those expire, I really have lost that investment. And so that really is a challenge for us. So the decision at the state level of how much financially to invest in antivirals really is a basis of, that's an at-risk investment. And am I better buying more masks or, investing something that I know will expire and I may not get any value out of it?
Dr. Schultz?
Just to reiterate some of the comments, I can't speak directly to the antiviral stockpiles, but to point out again or reemphasize the critical need for accurate, very rapid, highly reliable diagnostic testing to make best use of the stockpiles, however they are. And another element of that is another key role right now for public health laboratories working with CDC is monitor the emergence of antiviral resistance that we've already seen with one whole class of antivirals. And this is something that would have to be monitored throughout the pandemic period, which could last 18 months to 2 years. So however the stockpile sorts out, the laboratory, there's going to need to have that very rapid diagnostic testing and surveillance that goes along with it.
That's a good point. And Dr. Caldwell?
Yeah, it's concerning to me at some levels that there's so much emphasis being put on antivirals, which we don't even know are going to work. Investing millions upon millions of dollars on that, while at the same time not making a one-to-one commitment into the resources we need to actually get the vaccine or antivirals into people's hands. And that's where local health departments come in. We are the ones responsible on the ground for accepting the strategic national stockpile. And we have had experience in having moments where we've practiced trying to get medicine to people very quickly. Let's go back to the 2004 seasonal flu vaccine shortage, where there were delayed shipments and people were anxious and concerned, and the public became extremely vulnerable and was worried. We somehow in Dutchess County were able to give out nearly 6,000 doses in a couple days to our most vulnerable populations. But that is only actually because of the efforts that we had made in emergency preparedness and practicing. We did better with that. And we need there to be a recognition that the unknown strain, the unknown hopefully we'll be able to develop a vaccine quickly. But the amount of money that you have in antivirals, that if they work, maybe, are they going to take one day off of the illness, or are they actually going to save lives? We just don't know. And I think that if you're going to make the commitment into putting dollars into medicines. You need to at least make a one-to-one commitment into putting it into the strategies, the implementation strategies, the practice, and the planning at the local level.
That's a very good point. Dr. Lakey?
Thank you. I agree that antivirals are only one component of a comprehensive plan for the state. I think it is an important part of the comprehensive plan for the state. I worked this issue quite a bit this last legislative session in Texas. We were offered the ability to buy $34 million worth of antiviral medicines. We came out of the legislative session with $10 million, and that was a hard sell. One of the reasons that it was a hard sell was with ongoing health concerns in the state, spending $10 million for a medicine that has a 5-year shelf life, and the unpredictability of pandemic influenza made a lot of other issues seem more important at the state level than purchasing the antiviral medicines. I think that the 5-year shelf life played a key role in the difficulty we had in making the case for the state to invest in the antiviral medicines. And so I think that is a key issue that needs to be looked into.
And Dr. Lakey, and following up on that, can you describe the national policies that prohibit using these medications bought under a federal contract?
So under the federal contract, it was negotiated at a low rate and with a national subsidy. And with that, we are not allowed to utilize the medicines except for a pandemic, and so pandemic influenza. We're not allowed to rotate through the stockpile so that we could use so much this influenza season and replace it with additional antivirals that are purchased. Basically, it's just put on the shelf, and we're not allowed to utilize it except for the pandemic. And that's where this 5-year shelf life really comes into play.
That may make some sense to take another look at the contracts so we can fully utilize our resources. One thing we discussed, Dr. Lakey, yesterday I wanted you to expand on is in terms of hospital bed space, the availability. You mentioned a concern of yours in terms of your ability to inspect the hospitals as it relates to CMS's ability to fund. Can you elaborate on this, and what, if anything, would you recommend we do at the congressional, at the federal level to fix this?
Sure. The situation is that our agency does initial hospital licensing, initial inspections of hospitals to allow them to bill Medicaid and Medicare. We have been told that initial inspections for new hospitals are the last priority, that we are not allowed to do them unless all other types of inspections are done. And basically that is a situation that never occurs. And so we have multiple hospitals in Texas that are waiting inspections in order to come up and be able to bill Medicaid and Medicare as part of their business plan that are not allowed to do that at this time. And so we have 17 hospitals currently sitting in Texas awaiting, and they're ambulatory care centers and smaller hospitals that we can't inspect. There are other options for the hospitals. They can go through full JCHO accreditation. They can be deemed under a parent hospital, so they're part of a feeder system into that hospital, or if there's an access to care issue. The problem for Texas is we're not an access to care state, and so we've offered to use general revenue and other sources in the state to either take care of that backlog or to do the initial inspections. We've offered to be able to couple them with other types of inspections and been told that we can't do that. And so there are multiple facilities in Texas that we can't bring up because of those issues.
I'm curious with the other three panelists whether you're experiencing that same problem in your respective states.
I don't think we share that the challenge that Dr. Lakey is facing in Texas. I think our greatest challenge in terms of hospitals is the issue of capacity. Mm-hmm. And again, within Rhode Island, the hospitals operate on an inpatient basis at greater than 95% capacity on every day. And so when we talk about where would we accommodate surge, again, not just for pandemic, we had the experience in Rhode Island of the Station nightclub fire, and that was a challenge to try and despite heroic efforts by first responders and people at hospitals to create that capacity in a real-time event. And that really is the challenge, is to deal with the unexpected. So my concern on the hospital level is how do we continue to support them in difficult financial times to invest in preparedness when they're really trying to invest in their day-to-day operation to remain open.
Any comments from the other two?
And again, from a laboratory perspective, we've spent a lot of time working with the clinical labs throughout the state and bringing them up to speed in terms of emergency response, their role in a pandemic, and what the pandemic is going to do to them. We're all going to be affected by this. And they have real concerns as well, similar to what have been echoed here as far as their capacity to respond, keeping in mind they're critical to maintaining day-to-day patient care that has to go on anyhow, much less the complications that are going to arise from a pandemic. So right now we've been working with them, but they are feeling very much at a loss as to whether they're going to be able to respond adequately to serve their the clinical or their clinicians' needs.
Dr. Caldwell?
Yeah, in the state of New York, we're actually cutting back on hospitals and beds, believe it or not, because they feel there's an oversupply. So it's in some ways a reverse problem. But when you look at how are we trying to prepare for the large part of our population being sick and very ill, we are thinking that we're going to have a lot of people be taken care of at home. And right now, where part of our strategy and planning in Dutchess County and many of my colleague counties is to work with our home care agencies and to work with them and build their capacities to develop some unified emergency preparedness home care plans, enabling our residents to know that there'll be people available to deliver some medical and nursing care in their homes if they get sick. Now, are we going to be able to activate hundreds of ventilators, and where are you going to get the staff to activate these ventilators? And I just don't see it being a realistic possibility. I think there's going to be some type of very rationing situation. Is going to be hard. I mean, we're not going to be taking over hotels. People used to say, well, we're going to take over hotels and put people there. That's not going to happen. The hotels aren't going to want it. Nobody's going to want to go to the hotel, and nobody's going to staff the hotels. I think so we need to look at what already exists in our community, try to think of how people are going to approach this situation, given that it's not just going to be people getting sick. All kinds of things are going to be happening. There's going to be a distribution of food problem. People are going to have trouble getting their food and their water supplies and their other regular medicines. So I do have one other comment about the previous topic of pharmaceutical stockpile in pharmacies. Instead of us in Dutchess County sort of going out and buying our own mini stockpile, what we've done through our relationship building efforts is work with our local pharmacies. So we have a memorandum of understanding of all the pharmacies in our county to know what's on their shelves. And should there be an outbreak, they will then immediately inform us of what's on their shelves, so that will be our sort of natural rotating mini stockpile, which won't cost us any money. And they, of course, it may not have all that we want, but it is at least something that we can have some control over at any time, and it doesn't cost us any money. As a matter of fact, it's an investment in our continued relationship. Where it's not antivirals, it may be something else, like, for example, some other antibacterial that we may need for some other agent that may come along.
That's very creative, and I appreciate the chair's indulgence. And just in conclusion, I do want to stress again the importance of exercises. I think those are very important. I hope that your partner at the federal level will work with you on those. And lastly, Dr. Lakey, you mentioned the border, and I think that's of obvious concern on a lot of levels, but certainly from a health standpoint, in terms of who's coming into the country, I think we need to have a better level of control over who is coming into the country. And certainly when we had the avian flu outbreak, knowing who's coming over from those parts of the world that could be impacted. And I know that on the science and technology standpoint, there's been some pretty good technology that's out there that could potentially spot if someone has a high fever, for instance, coming through an airport. And so I hope that we'll be able to make some progress on that level as well. And with that, I yield back.
I thank the gentleman. I want to thank the panel for being here today, as well as the previous panel. I thank the witnesses for their valuable testimony and the members for their questions. We obviously have a lot of work to do in this area. We look forward to a continued partnership, both at the local, state, and the federal level, to make sure that we get this right and we can protect the American people from both the pandemic flu or another public health threat. Thank you very much again. The members of the subcommittee may have additional questions. for the witnesses we ask you respond expeditiously in writing to those questions. Hearing no further business, subcommittee now stands adjourned.
All right.